Hello, my name is Deb Smith. I'm an improvement consultant at Health Quality Innovators, or HQI. This educational event has been developed in partnership with HQI, the Virginia Department of Health, and the Virginia Hospital and Healthcare Association. Please take a minute to review the icons at the bottom of your screen. You'll see two green icons to the right. One is for the resources for this education, and the other is for the post-test that you will be taking after completing the education. You'll have two chances to achieve a 70% or higher in the post-test in order to receive your certificate for 1 nursing credit. I would now like to introduce you to your instructor today. Sue Maslin is the infection preventionist for Bon Secours Mary Immaculate Hospital in Newport News, Virginia. Sue, the floor is yours.
Thanks so much, Deb. Hello, everybody. As Deb said, my name is Sue Maslin. I'm an infection preventionist at Mary Immaculate Hospital in Newport News, Virginia. I'm also a member of APIC, and I'm also a member of the HAI Stewardship and on the Antibiotic Stewardship Committee as part of the HAI Advisory Group. So today what I'd like to do is talk to you about antimicrobial stewardship and tailor it toward nursing, because nurses play such a key part in antimicrobial stewardship. I am a registered nurse as well, so I do know what you're going through when you're at the bedside. Improving the use of antibiotics is an important patient safety and public health issue, as well as a national priority. The 2006 CDC guideline, Management of Multi-Drug Resistant Organisms in Healthcare Settings, stated that control of multi-drug resistant organisms in healthcare must include attention to judicious antimicrobial use. And as a nurse, you will have an excellent opportunity to help your patients with antimicrobial stewardship. So today I have some objectives that we're going to talk about. I'm going to define antimicrobial stewardship. I'm going to discuss the benefits of having an antimicrobial stewardship program. We're going to review guideline recommendations to implement an antimicrobial stewardship program. And then we're going to describe antimicrobial stewardship strategies within the hospital setting. Antimicrobial agents typically account for a large proportion of the pharmacy expenditures in the hospital. It's rare that probably you don't have at least 90% of your patients on at least one antibiotic. And an estimated of anywhere between 30 and 50% of antimicrobial use in hospitals, though, is considered to be inappropriate. Now think about that. Almost half of what we're doing every day is not considered appropriate. So, and then this inappropriate antibiotic use has been associated with the propagation of antimicrobial resistance and other adverse effects. And so as we go further and further with more and more organisms becoming antimicrobially resistant, wow, that's a big word, that we don't have as many drugs, as many antibiotics coming down the pipeline to prevent or to treat these infections. So preventing and limiting this drug resistance is really a very important topic. So the appropriate use of antimicrobial agents may improve patient outcomes, and definitely it can help reduce healthcare costs. Consider antimicrobial stewardship. What exactly are we talking about? The components of a good antibiotic stewardship program could include things like improving antimicrobial prescribing so that we only use antibiotics and antimicrobials when they're needed. We want to look at minimizing the misdiagnosis or a delayed diagnosis, which could lead to underusing the antimicrobials when they should be and are needed. We want to ensure that the right drug, the right dose, and the right length of duration of therapy are selected when an antimicrobial is needed. When I talk about that, I'm talking about start and stop days, so we just don't have an open-ended end date. We want to, an effective antimicrobial stewardship program will measure and track the use of antimicrobials and look to see what the best practice benchmarks are. And then the hope is that in doing an effective antimicrobial stewardship program, we will then slow and prevent the development of further antimicrobial resistance. Look at antimicrobial stewardship and look at the core elements, the CDC developed core elements for hospitals and nursing homes. You'll see that on the left-hand side. And they've also done the same for core elements for outpatient areas. So when we look at things like leadership commitment, what we're talking about is dedicating the necessary human, financial, and information technology resources to programs like this. For accountability, we're looking at appointing a single leader responsible for the program outcomes. Experience has shown that successful programs show that having a single leader, somebody that's accountable, and usually it's a physician leader, is an effective part of the program. When we look at drug expertise, we want to look at appointing a single pharmacist leader responsible for working to improve antibiotic use, so someone who's dedicated to that as their focus of study. For action, we want to look at implementing at least one recommended action, such as a systemic evaluation of ongoing treatment needed after a set period of initial treatment. For instance, having an antibiotic timeout after 48 hours and considering, if that drug is being effective. For tracking, we want to look at monitoring of antibiotic prescribing and resistance patterns. And between different facilities, there are different resistance patterns. So we want it to be specific to your facility. Reporting, we want to look at regular reporting of information on antibiotic use and resistance to doctors, nurses, and relevant staff. And then finally, for education, we want to look at educating clinicians about resistance and optimal prescribing. And so you could look at this program as being well into that education part of the core element for hospitals and nursing homes. Microbial stewardship programs are really a very important strategy to combat antimicrobial stewardship and to also improve patient safety. This is a requirement that was implemented by the Joint Commission, and if you have a Joint Commission visit, they definitely are going to want to ask some questions about your antimicrobial stewardship and what you're tracking and how effectively you've implemented your program. CMS also has that as part of their conditions that they look at. And when we look at a comprehensive antimicrobial stewardship program, it really is very essential to really look at using antibiotics rationally, definitely decreasing antimicrobial-related adverse effects. I'll definitely have to have a little moment of talking about C. difficile infections because we know about that strong tie to the use of certain antibiotics. And then, again, we want to look at reducing the emergence further of drug-resistant organisms. An antibiotic stewardship team or committee will really function at its best when there is a multidisciplinary focus. So some examples of members could be the ones you see listed on this slide, having an ID doc or a specialty physician, but it does not have to be an infectious disease doctor if you don't have one that is dedicated to your facility. You're definitely, although you're going to have a pharmacist. Having nurses there is very important because they're the people at the bedside. You're the people at the bedside listening to this. Having your microbiology leadership there would be a good person to attend. Having your infection preventionist present at the meetings is very important. Information technology is very important. They're the folks that are going to help you pull that data that you can look at for getting the best information that you can get back to the providers. And then other healthcare professionals and administrators, maybe somebody in your patient safety committee, maybe someone from quality. Those would all be very appropriate people to be attending this. But if you can get a multidisciplinary group, everyone based off of their practice area is going to look a little bit differently at this antibiotic stewardship, and all those people and their opinions will help make your committee more robust and very much more enjoyable to be a part of. And also, when we think about communication, improved communication between providers is very important, as well as improving our communication to our patients. That's a good strategy that your antibiotic stewardship program should include, especially when it's in its early stages of being developed. at some of the unexpected or untoward effects of antibiotics, you know, they're not benign medications. They really need to be treated very carefully and very seriously and only used when necessary, because we know, we have good studies that show that antibiotic use is associated with an increase in resistance to antibiotics. Definitely, that increases healthcare costs, and then you have other kinds of adverse drug effects. You can have people become hypersensitive, they can become allergic. Some of these antibiotics can be toxic as far as, damaging to the kidneys. You can have adverse effects according to the antibiotic. You can have associated complications if the patient develops diarrhea or colitis, or then goes on further to develop C. difficile infection. So, you know, this is a global issue. Antibiotic resistance is a global issue. It will affect all of us and can affect our patients. So it is a very important topic for us to discuss. We do also, again, know that increased antibiotic use can increase resistance. It can cause us to become resistant. I mean, how many times as a clinician have you had somebody being treated for MRSA, and then on a subsequent admission you find out they've got VRE? Well, what do we treat MRSA with? Vancomycin. And so when that body adapts and becomes more resistant, then it sets a patient up to have an episode of VRE. Extended spectrum beta-lactamase producers are, again, yet another type of resistant organism to the carbapenems. And then you've got, your carbapenem-resistant organisms. So all of these are as a result of increased resistance to antibiotics. When we look at who's at greatest risk, well, sometimes you don't have to look very far to look at within our own walls in a hospital, because who do we care for? We care for people that are already sick or immunocompromised. So they're within our walls, they're immunocompromised, and then what do? We're treating them with all kinds of invasive lines. So every time you increase, you decrease the integrity of the skin, or you put a catheter in a spot that doesn't normally have a catheter, you create essentially a pathway for things to grow. The body's natural response to devices that are, they are not born with, are to, migrate cells to that area. It's a protective device, and when you have those cells go, it increases a chance for other types of organisms to colonize and then to potentially infect the person. This slide is another example of some of the summary data. I'm not going to go over it specifically, but it talks about the incidence of, how many illnesses, how many deaths, and then further it talks about, C. difficile as being a very serious subsequent thing that happens secondary to antibiotic use. Okay? All right, so let's talk about your role as a nurse with antimicrobial stewardship. As a nurse, especially if you're a bedside nurse, you have a critical role in helping to promote antibiotic stewardship for your patients. One thing that you can do is be part of an antibiotic stewardship committee, but let's say you don't have the ability to do that. You are in a key place to help advocate for your patients, because as an antibiotic first responder, you're the person that's giving that medication to the patient, all right? You're the person that is teaching the patient about side effects, about the importance of, only taking it for what they're needing it for, and you are the person there that's 24 hours. You're the one that's monitoring them for, is it working, all right? Because if it's the right antibiotic, you're going to see a response to what that patient's illness is. As a nurse, nurses are the most common person to be at the bedside to be reporting a patient's allergies. And I'll talk a little bit more about the importance of asking focused questions towards that. But you really want to conduct a thorough and a very accurate recording of what that patient's allergy is to the antibiotics, okay? Also, a nurse is a very great advocate, let's say, in interdisciplinary rounds. If the patient is able to take PO medications or they're taking by mouth, they're eating and they're drinking and they're on an IV antibiotic that can be done by mouth, that's a cost savings for your facility, and it's an appropriate thing to advocate for your patients. That can, help decrease resistance, help decrease cost, and also could potentially help get that patient discharged more quickly, all right? When we look at the time of diagnosis to that first dose of the antibiotic, a nurse is a critical component of that, getting that medication to the patient as quickly as possible. And then again, observing for how that patient is going to respond to the antibiotic or any adverse effects that they might have and intervene quickly. So when taking an allergy history, a lot of people will say they're allergic to an antibiotic, but in fact they really can take the antibiotic without a problem. It may be that in the past they had what they thought was an allergy, but they've stopped taking it since then, so they never knew if that really was a true allergy. So really this taking a good patient antibiotic history is very, very important. So some questions. I don't know if they're ones that you've asked before, but think about some of these the next time you're taking an allergy question, asking about a patient's allergies. So, here's one. Does the patient remember having an allergy, or were they told it by a parent? Okay. Ask them what the reaction was. Nausea, diarrhea is not an allergy. I mean, look at any antibiotic side effect, and nausea and diarrhea is going to be one of the side effects. The side effect is not the same thing as an allergy. Ask them how long ago was that allergic reaction. It may have been something that they took as a child, and now they're a full-grown adult. If they remember, have them describe what happened with the reaction, okay? Did it happen right after taking the antibiotic? Did it happen minutes, hours, days later? And then what was their reaction? Was it their first dose? Was it after the first dose? Was it after subsequent doses that they had that allergy? If they felt like it was an allergic reaction, did they receive treatment for it, and what was that, okay? There's a big difference between, just not taking it and Benadryl, or then having to get something, let's say epinephrine. All right, those are big differences in how an allergy is treated. And then, has the patient taken other medications in that same antibiotic class? So these are all very focused questions that can help you delve into a little bit more of what a patient believes is. So when we think about converting a patient from IV to by mouth, a lot of antibiotics can be just as effective taken by mouth as they can intravenously. We want to make sure that they can take things by mouth. So, they need to be tolerating feeding, okay? So they need to be not having emesis or diarrhea, severe diarrhea, within the last 24 hours, meaning that they're not having an issue with their GI system. They need to be able to take other regularly scheduled oral medications, no documentation of having issues with absorption. And then here are a list of some of the antibiotics that are very easily converted from IV to PO that you might want to consider if your patient is getting these IV, if that might be a potential thing to suggest to the physician, can this patient go ahead and take it by mouth instead of by IV, right? As we look at antibiotic administration, all right, certainly early administration of appropriate antibiotics is associated with improvement in patients that have bacteremia and sepsis, so promptly giving them those antibiotics is very, very important. All right, so I'm going to shift gears just a little bit because we're going to talk about C. difficile. There's no antibiotic stewardship program talk that cannot have some slides that have to deal with C. difficile, all right? We know that C. diff can be an infection that can be very, very severe. Rates of C. diff infection are of concern. They're publicly reportable. They have increased nationwide. And we know that it is not just one thing, but we definitely know that there is a link with antibiotics. So when we look at antibiotics being the most important risk factor, that is something that we definitely want to look at. What can we control, okay? Also, we need to look at, control measures that can be in place as far as making sure that the environment is disinfected appropriately with a sporicidal, that, we don't have, cross-transmission between patients, so that as healthcare providers, we're washing with soap and water in between patients. And we also know that there's an association with acid suppression therapy. So, patients that are on protein pump inhibitors. I mean, just think about it. When you've got a medication that's altering the amount of acid in your gastric secretions, it's going to affect other things. And so we know that the use of protein pump inhibitors is also associated with C. diff as well. So when we look at a good antimicrobial stewardship program, we want to look at really focusing in on the use of the antimicrobials within our facilities. We want to look at that, the initial prescribing. Are we really using targeted antibiotic use for, what we're trying to treat? Are we looking at titrating therapy as quickly as possible? So getting those cultures, looking at the culture results, and taking those people off of antibiotics if it does not appear that whatever is growing is, able to be treated by the antibiotic that they're on. So we want to give them, this talk is not, don't give people any antibiotic, but it's really, let's make sure we're giving the right thing at the right time and not dragging it out. So let's look also, at other interventions that might be complementary to help prevent C. difficile. When we look at those kind of high-risk antibiotics, look at this list on the left-hand side, okay? The fluoroquinolones are very commonly associated with C. difficile. Clindamycin, the broad-spectrum penicillins, the broad-spectrum cephalosporins, and the carbapenems. Studies have shown that if we could decrease the antibiotics that are most frequently, so these ones on the left-hand side, by 30%, it could lead to 36% fewer C. diff infections. And so that's pretty significant. I will tell you, within my own facility, we have a very active pharmacy team, and we have seen that as their pharmacy interventions have increased to tapering down antibiotics, we have seen almost the same decrease in our C. diff rate. And I just don't think that is by accident. I definitely think it is about antibiotic. So when we look at the symptoms of C. diff infection, all right, what we're talking about is not just a little bit of diarrhea, right? We're talking about watery diarrhea, 3 or more times in loose stools in a 24-hour period of time. And then typically it's associated with other types of symptoms like fever, loss of appetite, nausea. The patients will complain of having their abdomen be tender, having some bloating going on. Yes, C. diff does smell bad, but there's lots of other things that do too, right? So it's not just that it's foul-smelling diarrhea, but that it is also associated with this profuse wateria. So when we look at strategies to prevent it, both C. diff and antibiotic resistance, they both kind of fall in the same kind of bucket of things that we can do. So we want to look at teaching our patients to not request to get an antibiotic if they've got a viral infection. We need to support our physicians when they go in to talk to patients and tell them, I really don't think that you should get on this antibiotic. We need to be very supportive of our physicians because it's hard for them too when patients are asking to be on an antibiotic and they don't understand what that risk is. So we need to be very supportive. We want to, if at all possible, get cultures before starting an antibiotic. We definitely do not want to treat colonization, okay? Colonization is different than infection. So we don't want to be treating patients that are colonized. We want to discontinue antibiotic therapy if, as they're going down a differential diagnosis, they find out that the reason the patient is there is not related to an infection. So we want to make sure that we don't forget to always look at daily necessity for those antibiotics. And in fact, in this example, pneumonia versus heart failure, the patient came in with a pneumonia that needed to be treated with an antibiotic, absolutely. But let's say they found out that that shortness of breath was due to heart failure. Well, that's not the, they can get an antibiotic all they want. It's not going to help them, all right? And it could harm them. So we want to make sure we're giving the right drug for the right reason. And then this is a very important slide, to limit the duration of antibiotic therapy. I think I mentioned that earlier in the presentation, that once a patient's on an antibiotic, it's not an open-ended thing. We need to look at what are the best practice guidelines of when that antibiotic should be discontinued, because it has a lifetime of efficacy as well, and there's no reason to it. So when we look at testing patients, all right, here's the question: why should we only test patients who have symptoms of C. difficile infection, right? Well, the reason is we want to only test them when they've got symptoms, because we don't want to test them if they're colonized. We want to, distinguish between community onset, which are those patients that come into our facility with this diarrhea, and they, we send a sample from when they're admitted to up to day 3, because after day 4, I think you're probably aware, it becomes what's called a hospital-acquired infection. It gets associated with your facility. It is part of, the pay for performance, and, is publicly reportable. So we want to make sure that we're testing at the right and appropriate time. When we use the C. diff PCR test in a patient that doesn't have symptoms, sometimes we may get a positive test that is not indicative of an infection, and especially if you send that after day 4, that's going to be considered a hospital. So when we look at the difference between colonization versus infection, here's another thing that I think patients and sometimes practitioners sometimes have to kind of think about, because infection suggests that there is something going on in the body that is not going to get better unless it gets treated, right? There are signs and symptoms, things like fever, things like pus, having an elevated white blood cell count, pain, all right? Patients have got clinical signs and symptoms. If a patient is colonized, they may have, let's say, something in their urine, but they're not symptomatic. They're asymptomatic, all right? We can have patients that have asymptomatic bacteriuria that we do not need to treat with an antibiotic because, again, they don't have symptoms. So it's important to distinguish between colonization versus infection. Again, here's another, and this is specifically to C. difficile, all right? If a person is colonized with C. diff, they're not having that voluminous diarrhea. They're not having the signs and symptoms, all right? They may still be shedding C. diff spores, but they are not, they are not showing signs and symptoms of being sick, all right? If they're sick with C. diff, they're going to have those signs and symptoms. They're going to have the diarrhea. They're going to have those other signs and symptoms. And so another thing is a recommendation is, let's say you've got a patient with a positive history of having diagnosed C. diff infection, and in the last 30 days they present, okay? If they are not having the diarrhea, if they've got formed stool, they do not get recommended to be retested, okay? Actually, if there's on here, if a patient has a history of a C. diff test in the past 30 days and currently having symptoms, we don't need to retest them because they probably still have it. So they get treated and not retested. I hope that made sense. But yeah, that's the best practice because you know that they have it. So, you just treat it. Asymptomatic bacteriuria, I think I had mentioned that in the couple slides before. It should not be treated with antibiotics. So unless the patient has the symptoms of a urinary tract infection. So just having bacteria in the urine without the symptoms should not be treated. So as a nurse at the bedside, I hope this is helpful information that you can take with you when you see results. So in closing, a couple key points that I'd like to help reinforce here is that both the Joint Commission and Medicare require healthcare facilities to have a plan for antimicrobial stewardship. And the antimicrobial stewardship programs are very important to help improve reducing the use of antibiotics, which can cause resistance. Staff nurses have a very important role in either being part of an antimicrobial stewardship committee or as playing a key role at the bedside and being part of an active membership in this stewardship program. Your role could be anything, including and definitely not limited to these things: advocating for IV to PO conversion, really asking those clarifying questions for a patient's allergies to really try to make sure we distinguish between a true allergy versus a believed allergy that really may not be actual. Looking at monitoring for any adverse effects to antibiotics, really working towards being very conscious and diligent in preventing C. diff infection and advocating for appropriate testing based off of symptoms, and then really looking at results and understanding the difference between colonization versus infection. The other thing is also to be, as I know you are, a very good advocate for your patient and helping with that patient teaching about proper use of antibiotics. In conclusion, please think about antibiotic stewardship as part of your daily interventions for your patients. Your patients are looking to you to advocate for their safety. We want you to conserve the resources of your facilities, be good advocates for your patients, and to really help reduce bacterial resistance, because we know that antibiotics, they're not making that many antibiotics, and so we really need to conserve what we have. We want to prevent further resistance, because I can't think of anything worse than having a patient that I could see a culture result that every drug we had in our arsenal they were resistant to, because there's really nothing that we can do if they are. This last gives you some other resources that you could look at. There's plenty of resources out there if you want to search the CDC website on it, Antimicrobial Stewardship Program, but there are a lot of resources. Here's a slide that can give you some of additional information. Presentation was coordinated through the lead agencies of the Virginia Hospital and Healthcare Association, the Virginia Department of Health and the Office of Epidemiology, and Healthcare Quality Innovators. Again, my name is Sue Maslin. I really appreciate your time and attention, and I think someone else will come on with a little bit more information. Thanks a lot for your time and attention today.
Hi, this is Deb Smith again, and I just want to remind everybody to take the post test. It is the icon on the lower right-hand side, the little green icon. After you take the post test, you will receive your certificate for credit, passing with a 70%. Thank you.